Hello viewers, I am Dr. Robiul. I work as a lecturer in pathology in a medical college hospital, and I am making this video for my students and also for you. Hope someone finds this helpful. Today we will talk about a topic from the nutritional diseases chapter, and today's topic is on vitamin D. This video will contain the introduction to vitamin D, followed by its chemistry, its dietary sources, metabolism, function. We will also talk briefly about vitamin D deficiency and vitamin D toxicity, and finish our discussion today by talking about the recommended daily dietary allowances or RDA of vitamin D. Okay, so a lot of topics, so let's begin. So first, we will talk about some introductory points regarding vitamin D. Now, always remember, vitamin D is one of the fat-soluble vitamins. And if you have seen my previous video on vitamin A, you will recall that fat-soluble vitamins included vitamin A, D, E and K. So these were the fat-soluble vitamins, and vitamin B complex and vitamin C, they were the water-soluble vitamins. So vitamin D has important role in maintaining the proper plasma level of calcium and phosphorus. And again, the proper plasma level of calcium and phosphorus are also important for maintaining proper metabolic function, bone mineralization, and even it has role in neuromuscular transmission. So now that we have known some introductory points regarding vitamin D, now we will move on and talk about the next topic, and that is the chemistry of vitamin D. Now always remember, vitamin D are a group of sterols. Therefore, they will contain a steroid nucleus, and that nucleus is attached with hydrocarbon chain. In the nature, we will have two forms of vitamin D. From the plant source, we will get vitamin D2, which is also known as argocalciferol, and from the animal source, we will get vitamin D3, which is also known as cholecalciferol. And one thing you have to remember, that these things are derived from their precursor or pre-vitamin forms. For example, argocalciferol is derived from argosterol, and cholecalciferol is derived from 7-dehydrocholesterol. So that was in short about the chemistry of vitamin D. And one thing you have to remember, vitamin D from the plant sources is poorly absorbed, so we will mainly focus on vitamin D3 because that is derived from animal source. So now we will move on and talk about the sources of vitamin D. Now always remember, vitamin D has both endogenous and exogenous sources. However, the endogenous source is able to provide up to 90% of the required vitamin D. So what is the endogenous source of vitamin D? Vitamin D can be synthesized in the skin from 7-dehydrocholesterol upon sun exposure. And we will talk more about that when we discuss the metabolism of vitamin D. Just remember that first in the liver we produce 7-dehydrocholesterol from cholesterol, and then that thing is stored in the skin, and that skin, upon exposure to sunlight or any artificial light that contains the ultraviolet B radiation, on that exposure those 7-dehydrocholesterol undergoes some photochemical reaction, and as a result vitamin D3 or cholecalciferol is synthesized. So that is the endogenous source of vitamin D. And the exogenous source or the dietary sources of vitamin D will include both animal source and plant source. However, as we have mentioned earlier, vitamin D from plant sources are poorly absorbed. So we will mainly talk about the animal sources. The animal sources of vitamin D will include oily fish, fish liver oil, milk and milk products, egg, liver, etc. So now that we have talked about the sources of vitamin D, now we will move on and talk about the metabolism of vitamin D. So, as you can see, I have drawn a flowchart in the whiteboard to discuss the metabolism of vitamin D. Okay, I hope you're still with me. You didn't run away just like my students do when I try to teach them difficult flowcharts. I even have to show them teddy bear to keep them calm. So look, I am also showing you a teddy. So look at the teddy, don't run away, because I will try to explain this thing in a very simple manner. So what did we see in the flowchart? Notice on the top part of the flowchart that we can get vitamin D from both endogenous as well as exogenous sources. Now, first let's talk about the endogenous source, and we have already mentioned that in the skin we have 7-dehydrocholesterol, and this substance, upon exposure of sunlight or any other artificial light that is containing ultraviolet B radiation, or if I want to be more specific, that is containing the ultraviolet radiation from the wavelength 290 to 315 nanometer. So upon exposure to this type of ultraviolet B radiation, 7-dehydrocholesterol is converted to pre-D3 and ultimately with heat that is converted to vitamin D3. Then what happens? Vitamin D3 is absorbed in the blood. Similarly, whenever we are talking about the vitamin D that we get from the dietary source, that vitamin D, either vitamin D3 from the animal sources or vitamin D2 from the plant sources, both are absorbed along with other fat substances with the help of bile salt and mycelium. So they are absorbed from the intestine and then they are packaged inside chylomicrons. Now, what are chylomicrons? Always remember, chylomicrons are one type of lipoprotein, and their function is to help in transport of lipid particles from the intestine. So they carry lipid particles from the intestine. So what will happen next? Vitamin D will come to the blood, and in the blood that vitamin D will bind with a protein which is known as vitamin D binding protein, or DBP. Now this complex, vitamin D and vitamin D binding protein, this complex will ultimately go to the liver, and what will happen in the liver? There is an enzyme known as 25-hydroxylase, and with the help of that enzyme, vitamin D3 will be converted to 25-hydroxycholecalciferol, or 25-hydroxy vitamin D. Now what will happen then? This substance, 25-hydroxy vitamin D, will then go to the kidney, and in the kidney we will have another important enzyme that is known as 1-alpha hydroxylase, and with the help of that enzyme, 25-hydroxy cholecalciferol will be converted to 1,25-dihydroxycholecalciferol, or 1,25-dihydroxy vitamin D. And notice that this enzyme, 1-alpha hydroxylase enzyme, it is induced by parathyroid hormone hypocalcemia, that is decreased amount of calcium in the blood, and also hypophosphatemia, decreased amount of phosphate in the blood. All these things can stimulate this enzyme, and that will lead to increased production of 1,25-dihydroxycholecalciferol. And also notice that this thing, 1,25-dihydroxycholecalciferol, again inhibits the function of this enzyme in a negative feedback mechanism. And also remember, this 1,25-dihydroxycholecalciferol is the most active form of vitamin D. And as we will see, this active form of vitamin D will have various roles on the intestine, on the bone mineralization, metabolism, and even on neuromuscular function and bone resorption. So what will be the role of activated vitamin D in the intestine? Now always remember, vitamin D receptors are present in the nucleus of most of the cells of our body. So we will also see vitamin D receptors in the nucleus of the cells of the intestine, particularly in the cells of the duodenum of small intestine. So first, vitamin D's active form, or 1,25-dihydroxycholecalciferol, will bind with these nuclear receptors. And also remember that these vitamin D receptors are also associated with another receptor which is called RXR. So ultimately heterodimeric complexes will be formed that will contain vitamin D receptor, and also RXR. And these heterodimeric complexes will then bind with vitamin D response element that is located in the regulatory sequences of the target gene. What will happen next? That will result in transcription of TRPV6 in the intestinal cells, and that will result in formation of a critical calcium transport channel, and that will help in calcium absorption in the intestine. Similarly, in the kidney, vitamin D's active form, or 1,25-dihydroxycholecalciferol, will stimulate expression of TRPV5, and that will also result in formation of calcium channel that will help in calcium reabsorption. So what will be the role of vitamin D on bones? And to explain that, you can see that I have drawn some osteoblast, pre-osteoclast and mature osteoclast in the corner of the board. So let's now talk about this part of the diagram. Now, activated vitamin D as well as parathyroid hormone will enhance the expression of rank L on osteoblast. Now, what is rank L? It means receptor activator of nuclear factor kappa B ligand. So this thing is present on the osteoblast, and its receptor or rank receptor is located on pre-osteoclast. So rank L, after being expressed, will be bound to the rank receptor on the pre-osteoclast, and that will result in differentiation of pre-osteoclast into mature osteoclast. And mature osteoclast will then secrete hydrochloric acid, and it will also activate enzymes like protease, and all these things will dissolve calcium and phosphorus from the bones and liberate into the plasma. So that is how calcium and phosphorus will be resolved from the bone due to the role of vitamin D. But one thing you have to remember, vitamin D not only has a role in resorption of calcium and phosphate from the bones, but it also has a role in bone mineralization as well. And the thing is, activated vitamin D induces synthesis of osteocalcin, and that is a protein that helps in calcium deposition in the bones. And also remember that vitamin D will also have role in metabolic function and neuromuscular function as well. So this was in short about the metabolism of vitamin D, and now we will talk about its functions. So as we have seen, vitamin D has very important role in maintenance of proper plasma level of calcium and phosphate. Vitamin D increases intestinal absorption of calcium and phosphate. Vitamin D facilitates in parathyroid hormone-induced calcium reabsorption in the kidney. Vitamin D also facilitates in parathyroid hormone-induced bone resorption. And we have also seen that vitamin D also has role in bone mineralization. It also has certain role in metabolic functions and also in neuromuscular transmission. So these were in short the functions of vitamin D. And now we will move on and talk about vitamin D deficiency. So how can we define vitamin D deficiency? Always remember the normal reference range of circulating 25-hydroxy vitamin D is from 20 to 100 nanogram per milliliter, and whenever the level is less than 20 nanogram per milliliter, that is known as vitamin D deficiency. Now, this deficiency can result from insufficient exposure to sunlight. It can also happen due to diet that was deficient in vitamin D or calcium. Less common causes of vitamin D deficiency will include disorders of the kidney, because recall, kidney had role in activation of vitamin D. And sometimes, less commonly, vitamin D deficiency can also happen due to some inherited disorders. Now, vitamin D deficiency will result in rickets in case of children, and in the adults it will cause osteomalacia. And also vitamin D deficiency can also result in hypocalcemic tetany, and it is a convulsive state, and this is happening due to insufficient concentration of extracellular ionized calcium. So now let's talk about rickets first. So vitamin D deficiency will result in rickets in children whose epiphyses have not yet been closed. And the skeletal changes that we will see here will vary according to the severity of this deficiency, the duration of this deficiency, and also on the stresses on individual bones. For example, during the non-ambulatory stages of life, during the non-ambulatory stages of infancy, during which the infant has not yet learned to walk, head and chest are subjected to the majority of the stress. So the bones of the head and chest will have the major skeletal changes due to vitamin D deficiency during the non-ambulatory stages of infancy. So what are the changes that we will see? In the head, we will see softening and flattening of the occipital bones. In case of parietal bone, they will buckle inward, and they will buckle inward during pressure, and whenever the pressure is released, they will snap back to their previous position, and this is known as craniotabes. We will also see frontal bossing, and the head will have a sort of a square appearance, and that will be due to excessive deposition of osteoid. Moving on to the chest, what will we see here? In the chest, along the costochondral junction, there may be excessive deposition of osteoid as well as cartilage, and that will result in some beaded appearance. So the costochondral junctions will appear to have beads underneath the skin, and this is known as rachitic rosary. So this is very important for your exam, so remember this term. This is called rachitic rosary, and it will happen due to excessive deposition of osteoid and cartilage in the costochondral junction of the ribs due to vitamin D deficiency. Also, the metaphysis of the ribs will be weakened and they will be subjected to the pull of respiratory muscle. And due to the pull of the respiratory muscle, the metaphysis of the ribs will bend inward, and that will cause anterior protrusion of the sternum, and that will result in a condition known as pigeon breast deformity due to anterior protrusion of the sternum. So these were the major skeletal changes due to vitamin D deficiency in Rickets in non-ambulating infant. So what will be the skeletal changes in Rickets in ambulating child, a child who has learned to walk? So in this child, recall that the spine and also the legs will be subjected to the majority of the stresses, and as a result the legs and the spine will be subjected to the skeletal changes in vitamin D deficiency. So here we will have lumbar lordosis and bowing of the leg. Particularly there will be bowing or bending of the tibia. So these were in short about the major skeletal changes that we see in Rickets, and now we will move on and talk about the another disease that happens in vitamin D deficiency, and that is osteomalacia. And always remember that this thing happens in adult whose epiphysis is already closed. So what will happen here? The contours of the bones are usually not altered. However, since in this condition the bones are not properly mineralized, and since there is derangement of bone remodeling, so the bones of a patient of osteomalacia are prone to fracture. Both gross fracture and also microfracture can happen in a patient of osteomalacia. And also remember, in osteomalacia the femoral necks and also vertebral bodies are most commonly affected. So now that we have talked about vitamin D deficiency, now we will move on and talk about vitamin D toxicity. And the first thing you have to remember is too much exposure to sunlight will not result in vitamin D excess or vitamin D toxicity. So that is not the cause. Then when will we have vitamin D toxicity? It can happen when a large dose or mega dose of vitamin D is orally administered, and it is also known as hypervitaminosis D. Now what will be the outcome of hypervitaminosis D in the children? It will result in metastatic calcification of soft tissue, for example of kidney. And I have a separate video entirely on pathologic calcification, and you can look into that video by clicking on the video section of this YouTube channel to know more about pathologic calcification and metastatic calcification. Now what will hypervitaminosis D do in case of adult? In case of adult, it will result in bone pain and hypercalcemia. So we are almost at the end of today's video. The last topic that we will talk is regarding the recommended daily dietary allowances of vitamin D. So the recommended daily dietary allowances of vitamin D is from 200 to 400 international units, or 5 to 10 microgram. So this concludes today's video on vitamin D. I hope this video was helpful. If you like my videos, do comment, share, subscribe and let me know. And for my students, I will also recommend you to go through your textbooks to know more information. Okay, that's all for today. Until next time, take care and stay blessed. Thank you.